Welcome to Conversations in Lung Cancer Research, a TOGA podcast where we discuss the latest breakthroughs in lung cancer research and treatment for Australia and New Zealand. My name is Associate Professor Malinda Itchins. I'm a medical oncologist and clinician researcher at Royal North Shore Hospital and Chris O'Brien Lifehouse in Sydney. The Thoracic Oncology Group of Australasia acknowledges the traditional custodians of the land on which we live and work. We pay our respect to their elders, past, present, and emerging. We also extend that respect to all Indigenous people. In today's episode, we take a look at thymic cancers, which are often the forgotten area in the thoracic malignancy space, yet a real focus still for TOGA. We're wanting this trial space to expand, however, we've had various challenges in terms of engaging industry as well as grant funding to advance research in this area. What we really want out of today's conversation is a practical overview on how thymic cancers are managed in Australia and New Zealand. Today on the episode, we're excited to have an amazing and expert panel, which is essential for this topic. The first is Professor Steven Kao, a thoracic medical oncologist at Chris O'Brien Lifehouse. Kia ora, Steven. Are you joining us today as an Aussie or a New Zealander?
Let's say both.
Love that. Our next member is Dr. Felicity Meikle, a cardiothoracic surgeon at the Waikato District Health Board in Hamilton. G'day, Felicity. Thanks for joining us.
Thanks very much, Mel.
And last but not least, Dr. Dasantha Jayamanne, a radiation oncologist at North Shore Hospital and Genesis Care in Sydney, our resident DJ and general best all-rounder in radiation oncology. Thanks for joining us, DJ.
Wow, Mel, you know my full name. Thank you so much for the introduction.
I had to practice it. So welcome to you all for this thymic edition of Conversations in Lung Cancer Research. I'm looking forward to you telling us all you know about thymic cancers. So to get things started, we'll start with the juicy science as well as the background of thymic cancers. Perhaps Felicity, can you talk to us about the prevalence of thymic cancers in New Zealand?
Thanks, Mel. So the prevalence of thymic cancers in New Zealand is really actually estimated to be about 2 per million. Although, to be honest, in my area in particular, we service about 1 million people. We probably have an incidence more of about 10 per million per year. Why that is exactly, I'm not entirely sure. We have a large Indigenous population in our area, and that may be what pushes the incidence and prevalence up in our particular space.
Oh, how interesting. So that's taken me to a point earlier in the piece. Risk factors for thymic cancers. Are there any?
Yes, well, certainly ethnicity does play a role. As far as Māori and Pacific Island peoples go, they tend to present earlier at a younger age than Europeans, and the incidence does appear to be higher. So certainly as far as local Indigenous populations go, that's certainly a risk factor. I'm sure the others have other risk factors.
Well, I might take it to Steven, as Steven, you treat a lot of thymic malignancies. What do you think about the prevalence in Australia? Do we know it? And any other risk factors we've been able to ascertain?
Look, I think it's not completely well characterised. There's been a couple of large-scale studies in Australia. And I think generally speaking, we would consider this to be quite a rare tumour type, and the quoted incidence is probably around 0.3 per 100,000 here in Australia. And like Felicity said, I think ethnicity does play a part in the differences in incidence, and I know that Asian folks are at a slightly increased risk for developing thymoma, and so I guess geographical variation would play a part in how often we see those rarer tumours as well.
Yeah. So moving on then to the clinical presentation, perhaps I'll take that to you now, DJ. What are the types of symptoms we're seeing people present with, and how do we typically work up a thymic malignancy? I say that as it may be different in thymic carcinomas versus thymomas.
Yeah, thanks, Mal. Yeah, I mean, with rare tumours, it's always hard to characterise what the commonest presentations would be. But I guess like other thoracic illnesses and malignancies and tumours in particular, at a small or early stage, I guess a lot of these things are asymptomatic. And so a lot of the time we're actually just picking these things up as a anterior mediastinal mass in someone who's completely asymptomatic, having a scan for something completely different to the concern of a tumor. So I think that's probably the commonest scenario. Obviously, as these tumors get a little bit larger, they do have the capacity to cause some local invasion. And I guess the commonest scenarios there are local invasion into the lung or the pericardium in very advanced stages. And then obviously, sadly, with some of the most more distant spread, they can certainly seed the mediastinum or the pericardium, as well as the pleural space. And there is a propensity towards distant mets in later stages. So quite a varied presentation depending on the stage and how aggressive this tumor is. And as we'll hear later, I guess it's just such a heterogeneous space.
One thing to add, which makes thymic malignancy quite interesting, is obviously the association with paraneoplastic syndrome, right? Because if somebody have a diagnosis of myasthenia gravis, then I think it's empiric that we screen for thymoma because it's absolutely associated. So one of the other interesting presentation is that they're coming with symptoms of myasthenia gravis, which is great for medical student education.
And I guess, and I've wondered, do the paraneoplastic phenomena tend to present at an earlier stage? And does that have then a prognostic implication to picking up the malignancy potentially earlier? So a question around the anterior mediastinal mass that DJ has alluded to. Does everybody who has one detected have a PET scan?
Ooh, that opens a can of worms because certainly for us, access to PET scan can be challenging. And really, you're only going to be scanning the patients who you're worried about distant metastases on. Someone who has a straightforward anterior mediastinal mass with no other indication of distant sites of disease would not get a PET scan in New Zealand. It's not part of our qualifiers, unfortunately.
How about in Australia?
Look, I think in Australia, we have a bit more access to PET scanners, right? And I think from our experience, if you think about the differential diagnosis of anterior mediastinal masses, it could potentially be hematological malignancy that we're not familiar with. And sometimes PET scan is useful in detecting occult nodal disease and things like that. And so it may point one way or another as to the provisional diagnosis based on imaging. And I guess from our experience, if we think that it's localized and we are pretty convinced that clinically it looks like a thymoma, then we don't necessarily do a biopsy. Sometimes we go straight to surgery, right? But I guess if PET scan can help us in terms of adding that extra information for us to make that judgment will be what our experience has been.
I agree. So I'll ask then Felicity and then DJ, who do you want to biopsy on in this domain as a potential differential?
So I really want to biopsy the patients who radiologically look like lymphoma over thymoma. So those are the patients, because they're not patients you would treat surgically. You treat them with systemic treatment. So they're the ones that you want to differentiate early. And typically the radiology for particularly diffuse B-cell lymphoma is quite obvious. And so we tend to pick up those patients radiologically and forward them on for biopsy. But also patients who perhaps you're worried about a carcinoma as well, just because the treatment modality for them has a slightly different pathway.
Yeah, I agree. And I wondered whether you would be utilising PETs to understand if there could be a higher grade component, because for DJ, you're often very involved, and we'll move on to your craft. But who are you thinking about to biopsy? Anything to add?
Yeah, I think the imaging piece is really interesting in thymic tumours. Obviously, the differentials we've all just sort of spoken about, and PET can help delineate some of that. But even just amongst thymoma, we know that PET is very heterogeneous in its activity from thymic cancers to low-grade thymomas. And I suppose the second point outside of CT and CT PET FDG PET that is to sort of think about the other differentials. I mean, rarely you can get some neuroendocrine tumors, and we look at other styles of PET. But I suppose more importantly, from an anatomical delineation of the lesion, an MRI is quite good as well, especially with certain sort of sequences and motion susceptibility sequences that can just improve the visualization of these tumors, and that can help certainly Felicity in understanding a little bit more about what the operative field might look like. But yeah, no, I think it's very interesting in terms of biopsy questions specifically. I agree. I think if there's any concern about what other lesion this could be, if it's certainly highly FDG avid and you're worried about lymphoma, or if you think it could be a seminoma, then certainly you might consider a biopsy. But otherwise, I think if there's enough suspicion that it's a thymic tumor, often we consider surgery up front.
And nodal enlargement, hypothetically, if we're not doing PET scans, tell me from your experience, may that then lean you to more be thinking about this could be a thymic carcinoma as opposed to a straightforward thymoma? Are you thinking on imaging? We've talked about obvious distant disease, but is there anything loco-regionally otherwise that, that helps you make that slam dunk upfront operative decision?
Yeah, I think so. I mean, if you have loco-regional spread too, then you are a bit more suspicious that you want to rule out distant metastatic disease, but also are you going to be able to surgically clear all of the disease too, and what are you going to target? So yes, in that case, it does absolutely help, but it's not the isolated single anterior mediastinal mass.
So we unfortunately didn't recruit a pathologist to today's podcast, and it would be the wrong thing not to acknowledge then the staging and grading of the thymic malignancy space. I'm happy for anyone to take the question around speaking about what we look at in the MDT postoperatively to help us understand grade and stage.
I can hear a pin drop, so I might take this one. So I suppose a very important question, and I guess there's two components to it. One is the pathological grade of thymic tumors, and I guess the simplest way to put it is to drop them into three boxes: an A, a B, and a C. And with A-type tumors, we think they're the most well differentiated and have the least malignant and locally aggressive potential. And then you've got the B-style thymomas, which go from B1 to B3. And B3 thymomas tend to be on the angrier, more aggressive side with a potential for metastatic spread, whereas the other two tend not to. And style C thymic tumors are the big, bad, ugly carcinomas, usually squamous cell carcinomas, in fact. And so they are the highest grade and need aggressive treatment. And then if we look at staging, of course, there's two staging systems generally adapted. We tend to prefer the Masioka staging system. It's the oldest and probably the most well known in thymic tumors. And the nuts and bolts of it are that Stage 1 tends to be localized within the thymic capsule. Once you get into stage 2, you're getting into the capsule itself. Once you're into 2B, then you're just past the capsule into the mediastinal fat. And with type C, generally speaking, you've got local spread, often into the pericardium or into the adjacent lung. And then if you're going into Masioka D, then you've got distant spread into either pleural spaces, lymph nodes, or distant spread of disease.
And Steven, in the therapeutic space, are there any other biomarkers that we're looking at postoperatively that may guide our treatment?
Look, as far as I know, there's really no validated biomarkers that guide our treatments, although we often don't consider the histological subtype as a biomarker. But I think it is in a way a biomarker, if you like, because in thymic malignancy, it actually differentiates what we will recommend in terms of immunotherapy, right? Because if it's thymoma, especially type A or B1 and 2, they are associated with a much higher incidence of immune-mediated adverse events versus the thymic carcinomas and B3s, where they are increased but not at a devastating level where we will not consider immunotherapy. So in a way, I think personally, I would consider that to be a biomarker, if you like, but there's no PD-L1 or particular mutations that lead us one way or another to recommend treatment systemically at this point in time, both in the localized disease or metastatic.
Thank you. And we're going to circle back to metastatic, no doubt. But let's bring it back to where it's at, the mediastinum. So Felicity, tell us about the people that you take back to the MDT and ask for assistance from other craft groups. Who are they?
Yeah, sure. Preoperatively, the patients that I bring to the MDT are very large tumours that potentially have invasion into significant structures, the heart, vascular structures, the lung, that look like they may have distant nodal mets or potentially distant metastatic disease or pleural disease. So those are the patients that I think need at least a discussion around neoadjuvant treatment before they have a surgical resection, if they're actually somebody who's able to tolerate a surgical resection as well. So they're also the people who need discussion. Are they actually going to be suitable for what could potentially be a very large, invasive and potentially life-altering operation?
DJ, who are you piping up about postoperatively?
Yeah, I mean, there's so much, like we've sort of discussed with these rare tumours, there's not a lot of evidence to guide treatment management decisions, and a lot of the data was is retrospective. So I will preface it at that. I would say anyone with a thymic carcinoma who has localized disease, we should be considering postoperative treatment, depending on the surgery itself. Depending on whether there's microscopic or macroscopic disease, we might even think about adding chemotherapy in these patients. And the dose is highly variable, but generally speaking, we want to be in the high doses like we treat lung cancers. So towards the 60 gray mark is generally what the literature would say. Outside of thymic carcinomas, I guess the real controversies are, what B-type thymomas should we offer adjuvant radiotherapy for? I think for B3 thymomas, as soon as it's gone into that pericardial fat or mediastinal fat, we do want to give some adjuvant treatment. So that's the stage 2Bs, and certainly the stage 3 is the angry version. For B2 thymomas, it's a little bit more controversial. There's a lot of grey zone in terms of who we should be giving adjuvant radiation to. NCCN will say any stage 2 onwards, we should consider it. I must say, I really do like to talk to the surgeon in these scenarios. I always talk to the surgeon anyway, but certainly in this scenario, Felicity would be very important to me in understanding, her concerns intraoperatively and whether she felt that there were some additional risks associated. I'd like to think about sort of how close this particular tumor gets towards the heart, think about the longer term thoracic radiotherapy implications on the patient and what long-term toxicities they'd live with. Because, of course, the well-differentiated thymomas, these patients have decades to live generally, even with their disease. And so we have to be really judicious about the adjuvant treatments we give.
Thank you. So you took us there with prognosticating, because there are many clinicians who don't see a lot of thymic malignancies. So we probably can't do justice to the prognosis of everybody. But for example, an operative, type A, B thymoma you've alluded to with an excellent prognosis, if there was some extra capsular extension, for example, and you may give postoperative radiation, how much are you meaningfully, potentially extending the life of that human?
Very good question. Very difficult to answer. I guess if we just think about the data that we have to help answer that, it's hard, right? Because it's biased. It generally looks at the patients that have been treated, and then it looks at some other population-based analysis or institutional comparator. So I would say I would use first principles here and say generally, if you've got microscopic disease with radiotherapy, we talk about a risk reduction of about about 50%, looking at other tumor groups that we treat. And that's probably the answer. So if you've got a well-differentiated thymoma and you say the risk profile is 5 to 10% of failure locally, then we probably drop that by half. And that's why I would suspect the value of radiation in that scenario is low. Whereas if you've got a moderate to high risk thymic or tumor or thymic carcinoma, then I think we do a little bit better in that risk profile. But yeah, I think it's generally ballpark figures when I talk to patients because the data is so varied and hard to interpret.
And then bringing it to the systemic therapy in the perioperative realm, Steven, we've alluded to neoadjuvant chemo for the thymic carcinomas. Are you able to let us know where we can help in medical oncology, pre-op, as well as any evidence post-operative, including for thymomas?
Like DJ said, rare tumor, really limited evidence, and it's really all predominantly retrospective reviews. And so I think we work on a lot of first principle here. And having said that, we know that response rate for CAP chemotherapy for thymoma is quite reasonable, around 30-40%. And carboplatin paclitaxel for thymic carcinoma has a reasonable response rate as well in the metastatic setting. So extrapolating that in the neoadjuvant setting, I think if our surgeons say, hey, it looks a bit dicey, we need some cytoreduction before we attempt surgery, then generally speaking, I would offer CAP chemotherapy if it's thymoma, and I offer carbotaxol if it's thymic carcinoma, followed by, in Australia, PET scan, just to see the response. And I guess post-operatively, we probably have less of a role than radiation oncologist. And so for thymoma, unless there's really macroscopic disease left in situ, I wouldn't consider adding adjuvant chemotherapy or even concurrent chemotherapy with radiation. But as we said, thymic carcinoma is more aggressive. And so yeah, I guess if it's macroscopic, so as the R2 resection, then I would definitely recommend concurrent therapy to radiation. In the R1 resection, I would also consider chemotherapy in addition to radiation.
And in the node positive R0 setting?
If it's node negative, I probably would not think of chemotherapy as adjuvant treatment.
But node positive thymic carcinoma completely resected.
If it's thymic carcinoma, I would consider that, yes, based on first principle. Having said that, I haven't really seen a lot of surgical resections where there are nodes being resected. What regional nodes, Felicity, do we actually see?
I mean, with the anterior mediastinal nodes in particular, and sometimes you do get into the paratracheal space as well. So that is perfectly accessible from the front if you're doing a stenotomy. I mean, it really does depend on what you're chasing. So, if you have an isolated, moderate-sized anterior mediastinal mass, then you are doing an exenteration of the anterior mediastinum, and you'll get some anterior mediastinal lymph nodes in that specimen, but we don't go chasing all of the mediastinal nodes if we don't have to. So typically it'll be your sort of station 3 nodes that you'll get. But when we send them off, we just call them anterior mediastinal. So we get away from the mountain nodal map.
So let's move to stage 4. I think an important space, obviously, with regards to systemic therapy. So a de novo advanced thymic cancer with perhaps a thymoma with paraneoplastic phenomenon. Let's think about how we're managing that. There may still be a surgical pathway that's important. Or Steven, you think you can manage that, promptly with CAP chemotherapy in those high response rates?
Oh, that's a difficult question. I mean, in general, obviously, if it's stage 4, I think there's definitely a role for systemic therapy. And as I said, I think in the first line setting, CAP chemotherapy will be the treatment of choice for thymoma, and carboplatin paclitaxel, in my mind, will be the optimal treatment for thymic carcinoma. Now, I think if people have myasthenia gravis, then have a big anterior mediastinal mass there, I would probably ask my surgical colleague, and in consultation with the neurologist, to see whether there's a role for cytoreduction of the thymic mass, taking into account of the perioperative risks with myasthenia gravis. So I think it's a complicated question, and it needs to be multidisciplinary input into that. But certainly, I think systemic therapy will be the cornerstone in that setting.
And so I don't really like charting 3 chemotherapy agents, although CAP does seem very important. 2 questions. What would you go to in a thymoma who is not potentially CAP eligible? And why do we think there's such high response rates in a not so proliferative, more well-differentiated cancer to chemotherapy?
Oh, Mel, you're asking all the difficult questions. Look, I think generally we believe that there's both thymoma and thymic carcinomas are platinum sensitive, in particular cisplatin. If you think that they are not suitable for triplet chemotherapy like CAP, I'll probably consider cisplatin etoposide, which is an alternative systemic therapy option. And I guess if they're cisplatin ineligible, while NCCN guideline does not include carboplatin there, I have had some success using carboplatin along with etoposide as the alternative to cisplatin etoposide in terms of response rate.
And then moving to the thymic carcinomas, sorry to keep you on the spot, you've alluded to our interest in PD-L1. We now have unrestricted access to immunotherapy in Australia for immunotherapy-sensitive cancers. Will you start using immunotherapy more in this population?
That's, again, a very interesting question. I think philosophically, if you look at the trials, and again, there's no randomized studies in this space. We're relying on single studies. And most companies have had a small single-arm studies looking at PD-1, PD-L1 agent of their product. And what has panned out is that pembrolizumab, for whatever reason, in their single-arm study, have consistently shown a reasonable response rate. And when I say reasonable, it's around 20-25% as a single agent in the second, third line setting. On the other hand, on the other studies like nivolumab and avelumab, their response rate seems to be a bit lower. And so philosophically, whether you think that it's a differing drug or whether it's just bad luck between single-arm study, it's a bit difficult to know. But the NCCN guidelines specifically only mention pembrolizumab rather than the generic PD-1 or PD-L1 approaches. I guess in Australia, now we have unrestricted nivolumab and ipilimumab available. I think personally, while we would still consider immunotherapy for thymic carcinoma, like I said before, I think the immune-mediated adverse event is still higher than other solid organ tumors. So I'm not sure that personally I would dare using the combo Ipi plus Nivo, but I think I would consider nivolumab in that setting. And of course, talking about rare tumor, we're never going to get evidence for randomized study in the first line setting, but there's some provocative single-arm phase 2 study looking at combination of chemo plus immunotherapy that looks like, interesting data. That's something that we need to consider as well on a patient-by-patient basis too.
Agree. But just so it's on record, in thymoma, even type C, you currently are quite uncomfortable to use immunotherapy given the high-grade immune-mediated toxicity.
The combination Ipi-Nivo, definitely.
But there are some thymoma circumstances where you may use immunotherapy.
In thymoma, I would not use immunotherapy full stop, would be what I would do. In the thymic carcinoma, I will not also use Ipi-Nivo, the combination CTLA-4 and PD-1 inhibition, but I will consider using PD-1 inhibitor alone.
Thank you. I thought that was just a really important point to make, given more immunotherapy availability and in this very rare circumstance. So bringing Felicity and DJ back into the loop, of course, in advanced thymic cancers, you have an important role in, stage 4 disease. Perhaps, Felicity, tell us about your practice and when you may become involved in advanced thymomas or thymic carcinomas.
Interestingly enough, I'm actually probably an unusual person to ask that question because we're an intracavitary chemo unit as well. And so for stage 4A thymomas and thymic carcinomas, so you're talking about pleural disease, we do actually offer those patients surgical treatment. So they undergo a period of neoadjuvant chemotherapy, systemic therapy, and then if they have a response and no distant metastatic disease, will come forward for a surgical resection of their primary disease and their pleural disease, and then have intrapleural cisplatin heated, obviously, because we do high tox here. And so those are the patients that we tend to pick up. We're happy to have the multidisciplinary discussion about who would be appropriate for that treatment.
Are we aware of any centres in Australia offering similar?
So I think there is a centre in Sydney, and I'm going to get that wrong. I'm pretty sure that I have done high tox at Peter Mac as well. I don't know whether the thoracic surgeons there do that routinely. But yeah, that's certainly a place where we've picked it up because it was used in mesothelioma originally, and we no longer operate on mesothelioma now. So we've moved to thymoma.
Yeah. And DJ, with regards to Steven?
Oh, I just wanted also just to add, because we've concentrated on the drug therapy for the two different subtypes of thymic cancer, i.e. thymoma and thymic carcinoma. I think it is important to say that the management principle is slightly different as well, because I think we know thymic carcinoma is aggressive. So typically we will want to get in there and sequence our what we have systemic therapy-wise without much of a watch and wait approach. With thymoma, we alluded to as well that it tends to be a very indolent disease with a 5-year survival rate, in excess of 20-30%, even for stage 4 disease. And so there's a bit of an art to managing stage 4 thymomas because we actually do a lot of watchful waiting as well. And we talk about whether they're symptomatic, whether their disease are close to a vital structure. And we actually use a lot of local therapy, as Felicity said. We don't use intracavitary heated chemotherapy, but we do pick surgical approaches or radiation. So we do a lot of that. And I think there's a role for that. And I think in terms of chemotherapy, we don't, keep treating them forever. We often give them a very, very long break because of the durable response to chemotherapy. But yeah, DJ can comment on his approach with local therapy in those instances too.
Just prior to that, you've alluded to the survival with thymoma. Can you hit us with some numbers for thymic carcinoma survival-wise?
I'm pretty sure the quoted survival is less than 5%. So the median life expectancy is about 29 months for low-grade thymic carcinoma and 11 months for high-grade. So it's pretty bad.
I've got 12 months median survival in my head for thymic carcinoma.
Same here, and I think it's good we call that out because it is really quite poor and the therapeutic landscape has not been improving. So DJ, tell us, symptomatically, survival-wise, advanced thymic malignancies, where are you playing?
Yeah, I mean, to dovetail with Felicity, Steven, and yourself in terms of comments for this, I think, they're vastly different for how I look at thymomas versus thymic carcinomas. I mean, thymic carcinomas, we think of almost like the lung cancer space, don't we, where we treat the bone mets and the distant disease like we would with any advanced thoracic malignancy. We treat for symptomatic relief, for impending issues with airways or compromise in that sort of way, pulmonary arteries, close to cardiac structures. We think about all those local sort of effects that thymic carcinomas could cause on patients who have uncontrolled disease. In thymomas, I must say, again, it's a real partnership with surgeons like Felicity. So, we've just got to be a bit mindful that if we add in local therapies, we do affect the way that surgery can be done, especially in the pleural space. So with most of my cardiothoracic surgeons, especially if we've got young, fit patients with even pleural-based disease, often they do multiple surgeries over many, many years. And I think that's a very successful way to manage some of these patients with advanced cancer. When it comes to a point where we feel with thymomas that patients are unable to have more surgery, that would be a time I'd add in local treatment if appropriate. But like Steven says, we'd sort of judge that with symptoms and what systemic agents might be available at that time. We've talked about the paucity of drugs in this space. And so local therapies, it can sometimes be helpful in improving symptoms for patients with both illnesses.
And Steven, so in a salvage or in a progressive circumstance with thymoma, and it may be years down the track, but they've perhaps had their maximum anthracycline dose and you need to become involved again. What are you thinking about for next line systemic therapies, and are there any targeted therapies in that space?
Again, I think it's a challenging space. So if there's a very long platinum-free interval, like we talk about for lung cancer, I often, again, offer some platinum-based treatment. And so my go-to platinum-based treatment, if they can't have further cap with limitation with anthracycline, I would use this platinum etoposide as a salvage. Of course, there's a lot of, again, single small number studies, suggesting that some single agent chemotherapy may be helpful, like paclitaxel or pemetrexed. But there, for thymoma, there's also very limited evidence also for everolimus, which may be used. Now, the other difficulty in interpreting systemic therapy trials is that in the clinical trials, because of the rarity, often they lump thymoma and thymic carcinoma all together. And so, for example, there are studies using VEGF type treatment like sunitinib and lenvatinib. And most of those studies have a mixture of thymoma and thymic carcinoma, which makes it really difficult to suss out which group is benefiting. My understanding and my reading of things is that those VEGF type tyrosine kinase inhibitors tend to be more effective in the thymic carcinoma space rather than thymoma.
Yeah, thank you. And I find that incredibly challenging as well when they're all lumped together trying to tease out the advantage. So I guess in starting to wrap things up, one important thymic malignancy we haven't touched on is neuroendocrine tumours, which can be the third, subgroup that are also ultra rare and maybe, associated with MEN1 syndrome, which in Tasmania, where I'm from, is not that rare. Any experience, please share, around importance to managing potentially a neuroendocrine tumour, Felicity, that comes out from the thymus?
Oh, well, I don't know that we would manage it any differently, to be honest. I actually am now struggling to think if I ever resected a neuroendocrine tumour from the thymus. I don't think I have. I've resected lymphoma, but I don't think I've resected a neuroendocrine tumour.
So that really speaks to the rarity.
Exactly.
Anybody else have experience or advice around these tumours?
I think it's even rarer than thymoma and thymic carcinoma. So I think you would treat thymic neuroendocrine carcinoma as per, neuroendocrine carcinoma that arises from the GI tract. And when we talk about neuroendocrine carcinoma, I think they're mainly the carcinoid type and atypical carcinoid type of neuroendocrine tumor from the thymus, rather than the aggressive large cell neuroendocrine carcinoma in the thymus. So I've seen a neuroendocrine kind of carcinoid type thing whereby I treated them like just like a GI tract, a neuroendocrine tumor.
And so if they're early stage, including also a thymoma, do these people get surveilled forever?
Well, it was discussed at our MDT, which was interesting because I learned that for thymoma, the recurrence is not that typical 5-year interval that we often have in our head as oncologists, because there can be late recurrence for thymoma. So the recommendation, I think it's that you should surveil those patients for 10 years. Whereas thymic carcinoma, I think it's more aggressive. And so that 5-year mark number in our head still applies. So I think for thymic carcinoma, you kind of surveillance your patients for 5 years. But the interval initially, I think it's not evidence-based. You can do 6 monthly like you do for lung cancer, or 3 monthly if you think patients are at high risk. But generally, 5 years for thymic carcinoma, 10 years for thymoma is what I would say is needed.
And I think that's really interesting because it is very nuanced, and this is a very heterogeneous cancer. And we've alluded to multidisciplinary team meetings being really important. And I guess not everybody has as much access. So, perhaps, and I guess to DJ, you work in a couple of places, including the country, getting these patients discussed in a higher throughput centre, you feel is important. And that pathway is, how do we promote it?
Yeah, no, absolutely. I think, like we've discussed throughout this session, there's a few touch points, and when we need to understand management nuances in this illness, I suppose the first is the initial diagnosis, whether or not to biopsy, who goes to surgery straight away, and then the discussion on adjuvant treatment. And because they are so rare, I would hope that, most people would discuss these patients either prior to surgery or shortly thereafter, just to discuss the pathology. I think it's always hard with the increasing number of lung cancer in our MDTs to try to find time for these rare tumours. But, one option is to obviously have a registry and a way of collecting data so we can all learn from each other. I think that's important in all of this. And I guess in the country specifically, we're quite lucky where we are. We've got an MDT from multiple members across the state. In some instances, we've got great surgical support from Sydney, and some of us as radiation oncologists work out in the country as well. And so we've got a great group of people, and we do discuss all of these sort of thymic and anterior mediastinal masses in that MDT. So look, I think it's one of these things where we have to discuss these rare things. They often present management dilemmas, and then as a way of audit, it'd be great if we could publish a little bit more from an Australasian experience in terms of some of these nuances we've discussed.
Yeah, couldn't agree more. And that's actually where I plan to cap off the podcast, acknowledging that us collecting our real world data is invaluable, and perhaps will also help us as a research community to push forward some more important investigator-initiated studies that we need to do. And obviously incorporating New Zealand, Felicity, as I think you alluded to, a registry being also needed across the
absolutely.
Dutch.
I mean, we do capture a lot of our MDM data, but our surgical data isn't captured yet. You have ANSTHOR in Australia, but we're not part of that just because of some political issues. But hopefully that will come very shortly.
Well, fabulous. I think we should wrap things up there then. And thank you all. And not sorry for grilling you on all the ins and outs of thymic cancers, but a good opportunity for us all to learn. That brings us to the end of the episode. Thank you so much to Felicity, DJ and Steven for giving all your expertise on thymic cancers. I certainly learnt a lot. As always, thank you for listening to TOGA's Conversations in Lung Cancer Research. If you enjoy our show, please rate and review us on Apple Podcasts or Spotify.